Hi, it's Brain Bites with me, Dr. B. Today, I'm going to be talking about serotonin and SSRIs and some of the chemical bits about how all of this works. Let's dig in.
Let's pick up where we left off previously with serotonin on the brain.
So, what about the effects on a person who takes an SSRI? So, the medications are likely impacting the physiology of what's going on immediately. Researchers can see this through imaging and through neurochemical studies, but they do see that there are changes right away. But the changes only happen in a subset of neurons, a subset of transporters, and it takes a long time. Like I said before, with the feedback, and it takes a long time for those effects to spread out and then be something that is notable to the person who's experiencing it. Another thing that can be helpful is asking somebody else who's not taking the medication, but has a lot of interaction with the person who is taking the medication to note changes. If you feel bad and you're taking a medication and you still feel bad, but you don't feel as bad, you might not necessarily notice that you're improving. But somebody else on the outside may notice some things like, oh, I saw that you got up more today. I saw that you were more engaged with your friends today. I saw that you went for a walk today. There might be things that are more notable to somebody else looking from the outside in to say, yes, it seems like the medication is doing something. It seems like there is some improvement. And then the withdrawal effects that sometimes patients experience if they run out of their medication or if they just decide, like, I don't want to take it anymore. So that may come from the abrupt changes in the serotonin. So if they suddenly stop taking their SSRI and you think of all those little transporters no longer having anything blocking them, suddenly all these transporters can suck up all the serotonin and pull it all out of those cell spaces where it's transmitting those messages. So that's not what we want to do. And it can cause some really uncomfortable withdrawal effects like dizziness, nausea, irritability, flu like symptoms. And that's because of all the different places where these serotonin transporters are. When suddenly you pull these little blocks off from everywhere, it can cause a lot of effects that people don't experience comfortably. I'll talk a little bit more about that in a few minutes. I'm just going to say all the different things that serotonin can affect. But I also want to say that not everyone with depression and anxiety has low serotonin. So we know that this stuff is multifactorial. There's genetic influence, there's environmental influence, there's a lot of different stuff that's going on, and we don't know what all the pieces are yet. But we do know that there are some people that have depression or anxiety, and it doesn't appear that their serotonin is low. Not everyone responds to SSRIs. In pretty much all the studies that show any SSRI, it looks like only about 2/3 of people will respond to any given SSRI. So that means a third of people are not responding to them. And that's, I mean, 2/3 is still better than none, but it's not great. It doesn't mean that I'm going to put you on medication and you're going to feel better. It's likely you'll feel better, 2/3 of a chance. Of the people that do respond to medication, 10% of those people are likely to relapse after 6 months of recovery while they are still on the medication. So this is another thing. This is one of the frustrating things I experience. And also, I mean, patients experience this too. It doesn't feel good to be on the medication and like, I'm doing it. I felt better. I'm taking the medication and now I'm depressed again. So it's a stat that we have. It's not great, but that's what we're looking at. In some of the studies that they did looking at this, patients were switched to a placebo after they had recovered from their depression, when they were no longer depressed but maintaining that stability on medication. Some people stayed on the medication and some people were switched to a placebo. The people that were switched to a placebo, only 50% of them relapsed. So there's something interesting going on there. So some people don't relapse at all, whether they're on a placebo or taking the medication, but then there's still that 10% that will probably relapse even on medication that worked. So because of all of the things that have to happen after somebody starts the medication, it's likely that they will still feel bad for a little while. And sometimes they may even feel worse because this process has already started. And because of all the downstream things that have to change, there's a lot of action that has to take place before you start to see those positive results. So this is one of the things that I try to work with my patients on and let them know, like, you might not feel better right away. Just because you're taking this pill doesn't mean it's going to work for you, your experience instantly. The medication is doing something on the molecular level right away. But to experience the changes of that, That downstream process takes a while. So that's the waiting game. So understanding that because the trajectory of depression, if they're already on it and they're getting worse, getting worse, getting worse, but they start the medication, they may still continue to feel worse for a little while the top part of the stuff is trickling down. So benefit, 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 but it takes a little while to get there. And then just about changing to different SSRIs, all of the SSRIs are a little bit different. Lexapro, escitalopram is the cleanest one. That's the one we talk about. It has the least amount of interaction with any other sites, any other active sites. But some of the medications like Prozac has a lot of action. It does a lot of different things. And at different doses, it can add extra action to just the serotonin piece that it does. It may have some more norepi action depending on the dose. So there are a lot of different things that these medications can affect. And so it makes reasonable sense when somebody's not doing well on one SSRI to stop that and switch to a different SSRI because the action is a little bit different. In the broad sense, is it the same medication? Is it the same class? Yes. But on the chemical level, it is not the same. And those different receptors are not reading that chemical as the same thing. So that's important to recognize. Just because somebody's like, I took Zoloft and it was terrible, I hated it, I had side effects, it didn't help, I don't ever want to take one of those medications again. Well, maybe we shouldn't try Zoloft again. Maybe we should try something different in the same class. So here's some basic stuff just about serotonin. I just want to touch on serotonin itself and all the cool things it does. And I wrote this out. So if you see me looking at my notes, it's because I don't want to forget any of these things because it does a lot of stuff. Okay, so first of all, it comes from tryptophan, which you get from your diet. So we've been talking all this time about how serotonin regulates moods. It affects feelings of well-being and happiness, and that's in like the higher brain regions. That's a cognitive piece of like how you experience like how well you're feeling. But then also in the brainstem, there's a lot of emotional processing and mood stabilizing, and that's more on the basal level. That's the kind of stuff that keeps your baseline. You know, feeling happy is up here, just managing your mood is down here. Serotonin helps to regulate the sleep-wake cycle. So it can promote relaxation. It helps with the synthesis of the melatonin hormone, which we know is the darkness signal to tell your body like, hey, it's dark out, like we're probably going to prepare for sleep soon. So knowing that it manages that is really helpful, especially knowing all the dysregulation people have with sleep when they have depression and anxiety. So this is another important impact that the serotonin can have. So taking an SSRI may help. It won't put you to sleep, but it may help with the overarching process of what serotonin is capable of impacting. So I alluded to before the GI effects. So it helps with appetite and digestion. So these are very simple, important life-based things. It regulates appetite and digestion. It signals fullness to the brain, and it helps you feel satisfied after you eat something. They already know that sometimes when you see abnormalities in the serotonin in the gut, if you have problems there, we can see things like IBS, and we know that is related in some way to serotonin, although we don't have it all figured out yet. But this is a clear spot where serotonin plays a part. This is also why we tend to see GI side effects in the beginning when somebody starts an SSRI, because of all of the action that happens there. This is another place where that Prozac can go in there and block those transporters. So things don't work right for the first couple of days while the body's like, what is all this that's happening right now? Before it starts adjusting and sensitizing in a way that makes sense. And then that balance is recovered. So vomiting is related to some action in the brainstem. And there are anti-nausea medications like ondansetron, which works on 5-HT3 as an antiemetic medication. So another thing that serotonin affects is that vomiting, and we don't want that. So we have medications for that, and it works on serotonin in the brainstem. Serotonin helps regulate clotting, and it's released by platelets to promote vasoconstriction and clot formation after there's an injury. And through vasoconstriction, it can also affect heart rate. So there are some different things that we can see at play here. If people are on other blood thinning medications, we may see somebody at risk for more of a bleeding disorder. So as somebody who's already predisposed to a bleeding disorder and then maybe is taking a bunch of NSAIDs or something, and then they're also taking an SSRI, this is something to be aware of. So that's why we talk to our patients if they have a bleeding dyscrasia, that this may be something that impacts that. Triptan migraine medications, they affect this pathway. So they affect the vasoconstriction, the heart rate, because there's some thoughts that that vasoconstriction is adding to the migraines, and it also affects pain. And pain is another one of the things that can be affected by serotonin. It helps modulate pain perception and how the body reacts. Another medication that works on serotonin for pain specifically is tramadol. A lot of people have heard of tramadol. Tramadol works on the serotonin system to help address pain. It also can influence the release of hormones like cortisol, which can also affect other endocrine function. So, this is another area that serotonin affects. It regulates body temperature through the thalamus, so it helps your body respond to the temperature outside. That's why perhaps some patients will report they feel very hot when they take SSRIs, or they take Boost Bar, which also affects serotonin. They feel like very hot and warm and sweaty. That side effect may be related to the hypothalamus and the temperature regulation. We hear patients complain about changes in libido. Serotonin affects arousal and orgasm. So if we're blocking those transporters and things aren't working like they're supposed to right in the beginning, especially, it can cause those side effects. And then, of course, we know that it's implicated in learning and higher cognitive function. It can influence neurotransmission in the brain areas that are responsible for cognitive function and learning new things. So it's important to note that if somebody is also taking another medication that works through the serotonin system, that these medications can have an additive effect on that serotonin system. So we talk about serotonin syndrome, which is a pretty rare thing that comes from having too much serotonin. So if somebody's taking a bunch of blockers that are doing a bunch of different things, then that could cause serotonin syndrome without just being on mental health medications. We get implicated for it the most because of SSRIs and all our other medications that work on the serotonin system, but there are other medications that do that as well. So this was really long and very in depth, and I hope that you found it really interesting. I hope that this has sated some of your curiosity about why SSRIs work the way they do, what makes these changes so important, and how we're actually helping when we give people these medications. Like, what is it doing that's beneficial? How is it harming? And what's the long-term effect? I hope you've enjoyed this today. I hope your brain is full of serotonin goodness. Be sure to enjoy more tasty tidbits at brainbiteswithdrb.com. Thanks.